Hello, and welcome to this Cardiovascular Innovations on-demand session on intravascular ultrasound, step by step. I'm Arnold Cito from the Long Beach VA Medical Center. This is my disclosure statement. I have no relevant disclosures except a grant from Philips. There are a few basic reasons to use intravascular ultrasound. Before PCI, you might use it to assess the lesion for significance, assess what type of stent you need and how long it needs to be, as well as whether there's calcification that needs to be treated with atherectomy before stenting. After stenting, you might assess for stent expansion and malapposition, as well as any complications such as edge dissection or tissue prolapse. It can also detect whether there's any residual disease that was missed by your stent. More recently, the use of intravascular ultrasound for lesion assessment has been downplayed by the publication of studies such as the first trial shown here, which showed that IVUS has only a modest correlation of roughly 60% with an FFR of less than 0.80. And this is despite using variable cutoffs and different reference vessel diameters. The one vessel where IVUS seems to be prognostic for an FFR less than 0.80 is the left main vessel, where a cutoff of 6 millimeters squared is prognostic. This is reflected in the guidelines, where the recent ESC guidelines allow and recommend the use of intravascular ultrasound for the assessment of left main lesions, as well as the optimization of left main and other lesions, as well as the assessment of stent failure. The older ACC-AHA guidelines have a class 2B for the assessment of non-left main arteries, but this is relatively discouraged based on recent data. Intravascular imaging is relatively underutilized when you consider the potential benefits. It's not just the reduction in target lesion revascularization from expanding the stent more. This actually has consequences in terms of cardiovascular death and myocardial infarction. The most recent meta-analysis, which includes randomized controlled trials such as the ULTIMATE trial and the IVUS XPL trial, show that overall the IVUS compared with angio-guided PCI, IVUS-guided PCI has a 37% relative risk reduction in cardiovascular death and a 29% relative risk reduction in myocardial infarction. Now, getting back to the basics of intravascular ultrasound, just to how to interpret the image. Well, basically it's an axial image of the catheter surrounded by the vessel and the adventitia. And the way to remember the layers of the vessel is the AMI moniker, which is the outer layer is the adventitia, the middle echolucent layer is the smooth muscle media. In between the media and the intima is the plaque, and that's the eccentric plaque that you see on the left. This is another version of a soft plaque that shows concentric plaque formation between the intima and media. And in contrast, on the right, a fibrotic plaque tends to have a very echogenic or bright signal, but unlike in calcification, doesn't cause a signal dropout or shadowing. So that's a fibrotic lesion, which can require some high pressure inflation and possibly a cutting balloon, but not necessarily atherectomy. Calcified plaques show up under IVUS as a bright white or echogenic structure with severe signal dropout behind or shadowing. An arc of calcium that's greater than 180 degrees reflects a plaque that probably requires atherectomy before balloon angioplasty. Other characteristics include a calcium length of greater than 5 millimeters or a calcium thickness of greater than 0.5 millimeters. And these may reflect lesions that require atherectomy or, in this most modern algorithm, lithoplasty, which may be coming to the US soon. One tip I have is to use rotational IVUS catheters as opposed to a fixed phased array catheter. The phased array of transducer tends to make the transducer tip very stiff compared with a rotational IVUS catheter, and this shows up in the crossing force required to cross a tight or tortuous lesion. The Volcano Phillips Eagle Eye requires sometimes 200% more force than the equivalent Boston Sci or even Phillips Revolution catheters or rotational catheters. Rotational catheters also have the benefit of having improved image quality. So on the left, you see the phased array catheter, which has 40 megahertz, whereas in the middle, you have the rotational catheter, which is also at 45 megahertz and has a much higher image quality. The HD IVUS at 60 megahertz on the right invariably is rotational and has the highest quality image, which is getting almost equivalent to OCT. Compared with QCA, IVUS will tend to overestimate the size of the vessel, but compared with visual estimation, IVUS will be much more accurate and have less inter-observer variability. So any small differences between IVUS and OCT in sizing the vessel are not likely to be relevant in terms of choosing your stent size. Many people are confused by the various algorithms used to calculate stent sizing in IVUS. And this European consensus document in May 2018 is very helpful because it indicates that the key points are to potentially use either a mean distal lumen diameter with upsizing 0.25 millimeters, or you're taking an EEM cutoff with a downsizing by 0.25 millimeters. And avoiding this, landing the stent edge into the plaque are your major criteria to size your stent. So if you take this example here of a vessel that has 2.75 EEM diameter at the distal end and 3.5 in the proximal end, well, you would choose a 2.5 millimeter stent because you would tend to undersize when using an EEM measurement. If you use the lumen measurement instead, which is recommended for any place where there's no safe landing zone, you're landing into plaque, then you should just size it to the size of the lumen, which in this case happens to be 2.5 millimeters. By avoiding oversizing, you have a lower likelihood of dissecting the landing zone. The result would be shown here, where you have a 2.5 millimeter stent distally post-dilated only to 2.5 millimeters, and then you take a larger 3.25 NC balloon to high pressure proximally to optimize the proximal result. The goals of imaging post-PCI, as mentioned previously, are to document whether someone has incomplete stent apposition, stent under expansion, or any edge dissections. Stent under expansion is defined as not reaching 90% of the distal reference vessel lumen area. Eccentricity can occur from severe calcified lesions, even with high pressure balloon dilatation, but is considered less important than achieving a maximal stent area of 90% of the distal reference. Malapposition, or incomplete apposition of the stent struts against the vessel wall, can occur for several reasons, including thrombus, dissolution, incomplete stent apposition, stent under expansion, etc. This is actually surprisingly better tolerated than stent under expansion. However, anytime you see a stent floating in the middle of the vessel, like this case, it means that you should be post-dilating further. Edge dissections are surprisingly frequent, but these can be left behind if it's less than 60 degrees in arc or less than 2 millimeters in length. So although these edge dissections are sometimes angiographically occult, some of them can be safely left behind if it meets these criteria for a small dissection. Tissue prolapse, or Swiss cheese effect of the plaque pushing through the stent struts, frequently cannot be corrected with post-dilatating balloons, and it's hard to distinguish this from thrombus. Some papers associate this outcome with a worse clinical outcome, and it might be an indication for prolonged DAPT. Residual thrombus is seen as having irregular edges with oscillation at the periphery and tends to be a lower density, lower echogenicity lesion. The context of a thrombus is theoretically important. If someone has a STEMI, a thrombus will always be there. However, if a thrombus is seen in an elective PCI, it means that you're at risk of stent thrombosis, potentially hyperacute stent thrombosis. So in summary, intravascular ultrasound provides us with diagnostic information beyond the angiogram. It helps us screen for calcium before stent implantation and help us plan for which stent to put in. It guides the sizing for these stents and balloons, and optimizes stent expansion and identifies complications. Thank you very much for joining us.